It's a true pleasure to receive you in this academic activity, because today we are privileged to receive worldwide renowned Professor Eamonn Quigley, who at present is the director of the Underwood Center for Digestive Disorders of Houston Methodist, and he's, well, okay, so you know who you are. But he's also been the principal investigator of the well-known, okay, that's your resume. So you graduated in Cork, Ireland, and you developed a truly exceptional academic career, including leadership as the guest of Gastroenterology of Nebraska University and as the dean of the School of Medicine, Cork. So also being the president of the WGO, and he's a member of an endless number of scientific societies around the world, which reflects his global recognition. He has been pioneer in many areas of this specialty, particularly in the brain-gut axis and motility, and especially in the role of gut microbiota. I'd also like to highlight that Professor Eamonn Quigley was recognized as ad honorem professor at the School of Medicine upon request of Professor Cohen, and ever since Eamonn has been close to our department by supporting us in multiple ways, and his presence here is another proof of his commitment. But in addition but beyond his resume, we are very grateful for his academic generosity, his closeness, and his permanent support for the training of the new generations. So, dear Eamonn, I want to welcome you, and please feel at home in Uruguay. Thank you for being with us, and we hope that we'll learn a lot in this lecture.
So, we're going to get started. So, Professor Cohen and I are old people. we are towards the end of our careers, and a few years ago I learned this lesson from a great person, and that was, when you're in academic medicine, how do you know that it's time to stop? Well, the first thing is if you're asked to write the preface to a book but not write a chapter, or you're asked to chair a session at a meeting but not give a lecture, you're nominated to join the Archives Committee. These are all yellow cards. But then there are people who get straight red cards. And that's when you begin to mumble phrases such as, in my time, when I was a student, in my experience. Or you're invited to give a talk on the history of your specialty or of medicine. Or you're asked to give a lecture on the future of anything. So I'm doing all of those today. So I'm definitely finished. Okay. So what I will do is I will take you through my own career, but I'm not talking about myself, I'm talking about what I learned and what I hope will be of value to you. So I graduated 50 years ago. In fact, in June, we will have our 50-year celebration back in Ireland. But you will be amazed at what we didn't have. We didn't have ultrasound. CT scans had not even been widely used. And it was all open surgery. There was no laparoscopy until many years later. And endoscopy was purely diagnostic, because polypectomy wasn't really introduced until the 1970s, and the first ERCP and sphincterotomy was not performed until 1974. So there was a lot we didn't have. When we came to treatments, even cimetidine hadn't yet arrived, which was the first H2 receptor antagonist. And for inflammatory bowel disease, all we had was sulfasalazine and steroids. This is a view of my university. But what we did have is that we were given instruction in medicine as a clinical art. And that has remained with me to this day. And even nowadays, with AI and everything else, medicine is still a clinical art. And don't forget, please don't forget, that involves an intimate interaction between the patient and the doctor. And that's the most important lesson I learned. I then went to Glasgow in Scotland in 1977 and spent 4 years there. And that changed the direction of my career, because there I worked with this individual, Geoffrey Watkinson, who was one of the senior figures in British gastroenterology. He also was a president of WGO back a long time ago. And I also came under the influence of this man, Sir Roddy McSween, who was a pathologist and in fact developed a standard textbook of liver pathology, which is still very much used today. And they worked very closely together, and every week we had a wonderful pathology conference where we looked not just at liver slides, but we looked at slides from all of the patients. And as a medical student, I loved pathology, and I saw gastroenterology as the combination of medicine and pathology, and that's why I went into gastroenterology. But in Glasgow, I now began to see medicine as a clinical science. Scotland has always had great strengths in medicine, and particularly in clinical investigation. Now, one of the people I came to know while I was in Glasgow, even though I never worked with him, was this individual, Sidney Truelove. And I always talk about him because nobody knows him anymore. But I'll tell you what he did. He did the first studies on the course and prognosis of ulcerative colitis. He demonstrated that 5-ASA was the active ingredient of sulfasalazine in beautiful studies. He was an early adopter of endoscopy, and he believed in close collaboration between gastroenterologists and surgeons. But every year, he held a course in Oxford where he worked, called Topics in Gastroenterology. And I was very privileged to be sent there by Geoffrey Watkinson 2 years in a row, and came to, not really to meet, but to be influenced by Sidney Truelove. But what people no longer remember is that he performed with Wits and with others, as you can see here, the very first clinical trials in gastroenterology. In fact, possibly the first randomized controlled trials in medicine. And this was a truly transformative development, because we nowadays, nothing will be approved without randomized controlled trials. And these two papers shaped the future of clinical trials. And you see some names there that have become famous ever since, like Richard Dahl, who was the person who convinced the world that smoking caused lung cancer. But he also wrote a paper on irritable bowel syndrome. And this was a paper that was written over 60 years ago. And all it was a series, a case series. It would be rejected by every major journal nowadays. And he described the demographics, he described the symptoms, and he also went on to describe post-infection irritable bowel syndrome. In fact, it's embarrassing for me having worked in irritable bowel syndrome for many years, to go and read that paper and try to answer the question, have we learned anything new? Not a lot, unfortunately. So the lesson I learned here was do not ignore the old literature. Not all areas have seen progress, and there's a lot to be learned from the old literature. One of the things you will learn is that these people wrote extremely well, and you will learn how to write a paper. Now, when I was in Glasgow, Geoffrey Watkinson sent me once a week to another hospital, the Southern General Hospital, to do a clinic and to do endoscopy with this individual, Jerry Crean. Jerry was also an Irishman, but an extraordinary individual. And he, many years before his time, was looking at informatics. And they had developed a program in Glasgow whereby when the patient came to the clinic, and this, remember, now was in the 1970s, they sat down at a computer and they answered standardized questions. And the results from the computer were then compared with the patient's history given to the doctor. And they developed algorithms for the evaluation of dyspepsia. And he wrote this paper about dyspepsia, which is beautifully written. And I'll just give you some excerpts. Although there seems to be no generally accepted definition of dyspepsia, the term itself seems to be used as a code word or shorthand description for a variety of symptoms, implicitly attributed to the upper alimentary tract that may or may not be related to food, perfectly describing the symptom of dyspepsia. So, new ideas are not that new. The technology to achieve them is. They had very simple computers. We can do so much more now using AI, etc. But the basic ideas were there. And this is a phrase that I love, which is towards the end of the paper, where he says, we think of dyspepsia as a disease space of undetermined dimensions occupied by many conditions that share a more or less common core of symptoms, some of which may coexist, and like others, we find it difficult to define. And I think we could actually change that and just say that any disorder of gut-brain interaction could be described in those terms. So we always need to be aware of our limitations. We're not as smart as we think we are. There are a lot of things out there we do not know. The other thing that Geoffrey Watkinson arranged for me was to go and spend a research fellowship at the Mayo Clinic with Sidney Phillips, who's shown here, who's an old friend of Henry. And Sidney Phillips was a gastroenterologist, but also a gastrointestinal physiologist. And I spent my time doing motility studies, in animal studies and in human studies. And this is just an example of one of these papers. But I learned much more than just motility. I learned from Sid that translating ideas into study design involves rigor and honesty. I don't think he ever wrote a word in a paper that he could not support with evidence. I also learned that a knowledge of gastrointestinal physiology helps understand symptom pathogenesis. I just watched some of the fellows doing manometry. If you don't know esophageal physiology, you won't understand manometry. But unfortunately, understanding does not always translate into diagnostic or therapeutic promise. We've done many motility studies throughout the GI tract, but there is still a lot that we have not made progress on, unfortunately. Around this time, we began to learn about the big brain and the little brain, or the gut-brain axis. And that was very exciting at that time. And of course it taught us that no man is an island and that the gut and the brain are intimately connected. Then I moved to Manchester in England and I worked with this amazing individual, Leslie Turnberg. He's now Lord Turnberg, still alive. He achieved every distinction in British medicine that you could. He was Dean, President of the British Society of Gastroenterology, President of the Royal College of Physicians, and named to the House of Lords. Now, he was a very gifted clinician. But he was also a very gifted scientist and obviously an amazing administrator. And he had done a fellowship in the US working with somebody that you will all know the name of, namely John Fortran. And they had done some very basic biochemistry and physiology to describe how fluid and electrolytes are absorbed across the gastrointestinal tract. And indeed, they described a unique channel involving bicarbonate and hydrogen. So I now began to learn that medicine was a translational medical science, and this was the new era that had arrived, probably for me a little bit too late, but the whole area of medical research began to change dramatically. Now, this takes me back to another transformative event that occurred around this time, and that related to ulcer disease. When I started in gastroenterology, all of the action was in ulcer disease. All of the professors did research on gastric acid and ulcer disease, and somebody once said that more chairs of medicine in Britain were based on acid than on anything else. And indeed, my mentor, Geoffrey Watkinson, had done an amazing study many years previously documenting the incidence of peptic ulcer disease. And around the time I came to Manchester, there was a lot of interest in not just acid, but also on mucosal protection, as shown here. And I got involved in this area and did what I thought were very nice studies, which were published in Gastroenterology, looking at the pH gradient across the lining of the stomach and the duodenum. But of course, this is all ancient history, and nobody looks at those papers anymore because what happened? Helicobacter pylori. What you will not, any of the younger people here will not be able to understand is that there was a time when we didn't know about Helicobacter pylori. And of course, this is a paper I recently wrote with actually a doctor from Latin America, from Chile, looking at some of the earlier documentation of what probably was Helicobacter pylori. But then, of course, we had the big discovery from Warren and Marshall. This is Barry Marshall, that's Warren. Warren died last year, unfortunately. And he is often forgotten. He was the pathologist who really described the organisms. Barry Marshall became a rock star. But anyway, no, this totally transformed the field of gastroenterology. About half of the academics didn't believe it, and the other half eventually believed it. So there are a lot, for me, and I hope for all of you, there are a lot of lessons to be learned from this whole experience. It really is a tale of dogged and I would say naive persistence coupled with real expertise. So Marshall was the naive individual, Warren had the expertise. It also tells you that clinicians can make a difference. They had won the Nobel Prize. So keep your eyes open. Expect the unexpected. Be open to new and crazy ideas, but be critical. And be prepared to concede when it is clear you are wrong. Many people did not concede and looked like fools. Get over it, move on. So then I made another move. You're getting dizzy at this stage. So I moved to Omaha, Nebraska in 1986. This is what most people think Nebraska is, just all cornfields. But I was recruited there by another amazing individual, Michael Sorrell, who became one of the best known hepatologists in the US, in fact in the world. And he was a pioneer in liver transplantation. And this is an interesting story. The first liver transplants were done by Tom Starzl in Denver in 1963. They all died. But then people continued to do some liver transplants. The outcomes were terrible until Roy Kahn in Cambridge in England discovered cyclosporin in 1979. And if you look 10 years later, you're now talking about over 70% survival rates, so a dramatic change. And this is just showing you the current survival rates for liver transplantation. Now I expect 80-90% survival rates compared to back then. So this was a truly transformative development. But also, there's a lesson here that if you persist, if you dedicate yourself, and if you innovate, things will work. And of course, the other thing I learned, maybe the only thing I've been good at, is being an opportunist. So here I found myself in Nebraska, where they're doing a lot of transplants, they're doing a lot of looking after a lot of liver patients. So I began to collaborate with a surgeon, the chair of surgery, looking at motility in patients with liver disease and in liver disease models. And these were 2 papers we published at that time. But I made a big mistake. The first author in this paper was the son of Dr. Sorrell, and I misspelled his name. It should be 2 R's, not 1. And his father pointed this out to me. He was not happy. Now, the other thing that happened around then was hepatitis C. And this is a very interesting story. So when I was a medical student, and when I was working in Glasgow, we began to see patients who had hepatitis, but it was not A, it was not B, so we called it non-A, non-B. Whenever you see something like non-this or non-that, you know that we don't understand what we're talking about. So Harvey Alter, who subsequently got the Nobel Prize, was very smart, and he said, a long time ago, additional human hepatitis viruses may exist. And then it began to be described in relation to blood transfusion and IV drug use, and of course, eventually, hepatitis C was described. And this is the timeline, all the way from the first descriptions of transfusion-associated hepatitis to the winning of the Nobel Prize. And a number of years ago, along with other associate editors of Nature Reviews, we were asked to select our top discoveries in gastroenterology over the previous 25 years. Now, obviously Helicobacter was one, but to my mind, this was another. And indeed, over the span of my career, a disease emerged, its cause was defined, and a cure developed, which is extraordinary, because that's now totally curable disease. And that's from the paper that I mentioned. So, clinical observation, great science, and concentrated effort and resources do pay off. So, the clinical observation was obvious. Then companies invested a lot of money in trying to find the virus and then, of course, to develop the treatment. Then I went back to Cork, as Carolina mentioned, and there I worked with Fergus Shanahan, who's shown here. He was the chair of medicine. And I worked in the Alimentary Pharmabiotics Centre. And I was very lucky because this was the time when the microbiome was beginning to be discovered. And this now is the APC group in 2025. So it's grown from about 5 individuals to, I don't know, 200 or something, scientists and clinicians working in the area. So what I learned there, which is true everywhere, is that modern medical science needs investment, clear direction, and a lot of collaboration. Be open to collaborating. And this was the arrival of the molecular era, where we went from plating and identifying bacteria to, of course, whole genome sequencing. And this is the so-called microbiome revolution. This is from Marty Blaser, and he traced the development of the microbiome from infancy all the way through to adulthood. But is it really a revolution? I would say it's not a revolution in medical science, it's actually a revolution in technology. So the reason that we can do all these studies is because of advances in molecular microbiology. Now, I mentioned the gut-brain axis. If you look at the recent literature, you read a lot about the microbiome gut-brain axis. And this is one paper which is looking at how the microbe may influence the gut. Now, I mention this not because I think this is a great discovery. In fact, I don't think it is. But it's an example of how we can get carried away and how we can overinterpret animal studies and not rely on human studies. Because while it is, and this is even more detail showing, this is the so-called BRAC hypothesis, which maintains that Parkinson's disease originates in the gut. As a gastroenterologist, I think that's a great idea. And it says that the microbiome leads to inflammation, which leads to development of alpha-synuclein in the gut, which is then transported via the vagus. This is a wonderful theory, and people suddenly believe that the microbiome causes Parkinson's disease, and that's the way to treat it. But there are many problems with this hypothesis. So don't overinterpret the data. Because when we really think about it, where is the evidence that a disturbed microbiome causes disease? Obviously, in GI infections and infestations, that's clear-cut. And there are other very fascinating examples where the microbe can initiate immune-mediated disease, such as Guillain-Barré and Campylobacter and uveitis spondylitis in people who are HLA-B27 positive, like myself. There is antibiotic-associated diarrhea and C. difficile-associated diarrhea. This obviously is Helicobacter pylori. Then there are a very few examples where fecal microbiota transfer actually is curative, namely C. difficile, and finally there's hepatic encephalopathy. And this is an example of the progress that's been made with FMT in C. difficile related disease. But again, we mustn't forget ancient history. If you read the internet, which I don't advise, every day you'll see people talking about dysbiosis, leaky gut, and how dysbiosis and a leaky gut lead to everything you can think of, from skin rashes to dementia, name it, everything. In fact, the best example of a microbial-related metabolic disease was described 70 years ago by Sheila Sherlock, when they described how the digestion of protein in the gut by bacteria led to the production of ammonia and to hepatic encephalopathy. So again, we haven't made a lot of progress. So most recently I moved to Houston, which is a large modern academic medical center with an enormous focus on quality, innovation and outcomes, but facing challenges of insurance and of the cost and care of delivery to all. Methodist is a large private hospital, but we also do outreach to the community, to people who don't have insurance. And we are adapting, responding to this tremendous explosion in information, electronic medical records, AI, and biotech. It's an enormous challenge. And we also serve a very diverse population, which is an enormous opportunity. We're supposed to be the most diverse city in the US. And that, of course, gives us an opportunity to address a very important issue, namely the inequality of healthcare and the inequality in terms of outcomes. So if you look at these graphs, I won't go through them in detail, but they relate to various ethnic groups in the US. And what you can see is that not all the graphs are going in the same direction. You can see here the colon rectum is going down, except the group in green, who are Native Americans. If you look over here at liver and intrahepatic bile duct cancer, again, a lot of the graphs are going down, but some are going up. So there are major disparities in outcomes for cancer still in this day. And I mentioned this earlier when we were visiting the unit. There are fascinating lessons to be learned from studying disease around the world. So this is looking at inflammatory bowel disease. I would recommend this paper to you. So if you look at what's happened with inflammatory bowel disease since it was first described, and very recently, sorry, I'm going back. It was first described back here. You see that it began to increase progressively in the Western world, but was non-existent in the developing world. And now it's beginning to appear in these newly industrialized countries. And as I mentioned, as we were walking, it is predicted that in the developed world, 1% of the population will have inflammatory bowel disease by the year 2030. And this seems to be closely related to the development of these countries. Whether it's diet or environment or microbiome, we don't know, but clearly we have a lot to learn from that. And I would say, don't be afraid to go back to the phenotype. This is a study from Chris Black and Alex Ford, who are friends of Professor Olano. And they recently started looking at irritable bowel syndrome all over again. So they took a large number of people with irritable bowel syndrome, and using a technique I don't understand, they looked at all of their features, their symptoms, their comorbidities, etc., and came up with totally new ways of classifying them. And basically, what a lot of this comes down to is showing the importance of psychological distress as a feature in these various groupings. So how about the future? So as in the past, some developments will be transformative, but most will be incremental. And we see that in cancer, for example. I can't predict what will be transformative. Hard work, good science, and commitment will achieve the latter. And we see that, for example, in the development of checkpoint inhibitors and their gradual use, progressive use across cancer. Ignore the old literature at your peril. A lot of the answers are there if you look. As some of you know, I write a lot of reviews, and in doing that, I read a lot of older literature, and you often walk away embarrassed because what you thought was your original idea was actually there for a long time. Because many ideas are not as new as you think, but the technology to turn them into reality is, and that's what AI is bringing us. New tricks do not necessarily mean progress. Just because you can measure something does not mean that it's important. So just because you've got a shiny new scope or can do something doesn't mean that it's actually going to help anybody. Be prepared to retrace your steps and start anew. Now, what will change? I'm absolutely convinced that AI and virtual reality will change everything from direct patient care to imaging, surgery, and endoscopy. And we have to be prepared for that. You young people are much brighter, you're much more tech savvy, you will do very well. And we already are seeing places where you have virtual reality-led patient encounters and treatments. You've got AI-generated management algorithms. You've got Apple Vision in surgery and endoscopy, and AI interpretation of digitally acquired images. It is possible that radiologists may become redundant, because any digital file can be analyzed by AI, and eventually will be analyzed by AI. Will diagnostic colonoscopy disappear with better stool and blood tests? I think, like ERCP in my time, colonoscopy will become a therapeutic procedure. And we'll see a lot more of miniaturized diagnostics like wearables and capsules. What about all the omics, metabolomics, metagenomics, metatranscriptomes. They have the potential to lead to personalized medicine, but we're not there yet. We will have more immune-mediated therapies. We have great success there. But also, and I would say this particularly to the young people, you're going to have to be prepared to contend with other voices that are anti-science and that are going to cause you great difficulty. And we unfortunately have one of them leading health in the US at the moment. And this week, in fact last week, The Lancet described his first year in office as a year of failure. But you cannot, it may not be here in Uruguay, but in the United States, you cannot believe how opposed to science some people are. And that's a very big danger. And I urge all of you to stand up for science and to be advocates for science and scientific medicine. Thank you very much.